started, we had only not more than 100 pediatric endocrinologists in the country. And the burden was huge. So there were thousands of cases of pediatric endocrinology were there, but then there were very few to cater them. So what we thought that there was a need somehow to have bridge in between them to develop special interest in pediatricians and physicians, and then they can really match and manage the overall case. Since then, there have been definite improvements which have happened, and now so many new things have happened. But this was what when I started in 2007 in that regards. So we started off and we realized that awareness was a major problem. So whenever we talk of a disorder, we know that there are three things: awareness, accessibility, and affordability. Now, everybody says it's affordability, especially when it comes to hormones. They are expensive, more difficult to get, but it's actually awareness. So we started with pediatricians' awareness. This was in 2012, and we can see many of the people who are still there. Many of the faculty is the same from that time. It's continuing from there. And then we conducted a number of programs across the country. We developed 6 modules, which are still the base of many of our courses. Till now, we have conducted 120 workshops, 15 practical pediatric endocrine courses across the country, and 5 advanced pediatric endocrine symposium. This is the 6th one that we conducted. So this was the first one in 2017, and we can see Dr. Hemchand here. So he was there right away at that point of time. Again, Dr. Hemchand talked about bone age. We discussed about this. Then there was a couple of year gap because of COVID. Since then, we have been having annual events every year. Every time we have got very good people coming from across the country. Now, after conducting so many programs, what we realize that once you conduct the program, people forget about that. Whatever you teach, they will just don't remember. And it is too much effort to go in terms of money, in terms of time, manpower, and everything. So we thought of using the power of social media to highlight that. We set up this channel, which is now one of the largest channels as far as pediatric endocrinology is concerned. And it has been viewed across the globe. It provides, there are over 400 videos and everything on pediatric endocrinology. So anything and everything, it's available there. We then thought of in terms of systematic approach in terms of pediatric endocrinology learning. So we started off with our fellowship program in 2017. And as Dr. Ravindra was saying, that we are now recognized by the National Board of Examination. And it was in fact a dream for the last 10, 15 years that we were pushing for pediatric endocrinology fellowships, which were not available from NB. And now finally the dream has come, and BJ Wadia and our center is now the 2 centers which are going to provide training in pediatric endocrinology. Now, what we realize that even physical fellowships, many people who have done training and who are in practice or doing some medical education, they are unable to really come in for 2 years because it's very difficult for them to join and leave the practice. So we started with online learning in terms of medi classes followed by books. And then we thought if you want to empower people to develop applications so that they can use, and we discussed some of the innovations just recently. Our fellowship started in 2017, and both of them are here. Dr. Neha and Dr. Chetan, they started with the first program. Dr. Riddhi and Dr. Sajali was also there in the second group. Dr. Pratik is currently in UK. Dr. Sayan and Dr. Naveen are now pursuing DM courses in PGI Chandigarh and at AIMS Delhi. Dr. Manoj was here. As we can see, Dr. Vibha has joined with us as a consultant. Dhwani is currently in Patna. So we have people across the country. And we have got Dr. Alapan and Sandeep who are still there, who are working. And Dr. Nimisha is the last one to join. So we've got 13 people who have joined. And hopefully very soon we will have the National Board Accredited Fellowship, which will start here. Our learning portal provides validated tools for evaluation, assessment, and pediatric endocrinology, including a full fellowship in pediatric endocrinology. So we launched around 3 years ago, fellowship program in pediatric endocrinology, which was a very, I would say, a tough program. It has 2-year learning. Every 2 months, there are online exams. There are continuously lectures every week. Every 6 months, there is a 5 days program in which they come, they see a lot of patients, we discuss with them, and then this program happens. So there are 4 sessions which are there. We have developed a mobile application, which in fact is the most downloaded endocrinology app. And we talked about publications there. We are developing other tools like personalized intelligent EMR, which will help guide evaluation and management of pediatric endocrine disorders. We have developed BIG, the bone age assisted interpretation of growth, which recently Dr. Vibha was just talking about how it will help assess puberty, growth, bone age, and obesity at one single click. You will be able to get all the results. We are developing a personalized expert for nutrition in which it will analyze all your meal items in terms of lot of input which we don't know about glycemic load, all the other aspects. And then it will also provide based upon the requirement, the recommended 7-day allowance. So automatic diet chart will come in for patients, which is coming up. We have already developed the Diabuddy app, which provides insulin dose guidance based upon glucose as well as carbohydrate counting, which is there inbuilt in the app. And this is being validated right away. So hopefully next time we would be launching it in a proper for a general use in that perspective. We have got number of books, basic, pediatric, and advanced. So we have tried to do a lot in this area over the last decade or so. Many of our efforts have been recognized. As I showed, Dr. Riddhi won the award for Best Bone Age Presentation at Kolkata, Dr. Sayan for Puberty Interpreter, Dr. Alapan at APES, Dr. Dhwani won the Kaichi Kida Award for the DSD Interpreter, Bone Age Assisted Interpretation for Growth, Dr. Vibha. Then also, so all of presentations have been there. There are a number of publications coming out of our tools, which have been validated and developed. So our fellowship in pediatric endocrinology, as I said, is a comprehensive one. There are over 100 modules, approximately 1,000 hours of videos that people have to watch. Pre-test, post-test, live lectures are there. There are on-site 4 visits with hands-on exposure. Assessments are done bi-monthly, 6-monthly, and an exit exam. And then there are other opportunities to collaborate in terms of research, learning, and teaching. So we have had multiple, we have now 9 on-site courses. This happens every 6 months, started from 2019. To date, we have had all these on-site courses, and we can see many of the places which are here also. So this was the last course which was done just in June 25. And all of them, I think most of them are here. And this was the extensive program in which we had 300 patients coming from growth, puberty, thyroid, electrolyte, all the disorders. And they were discussed in intensive fashion. And discussion was there. So till now, 48 people have been awarded fellowships in this program. Ongoing 72 people are doing fellowship. There are many other courses also where people are enrolled. That number goes to thousands or something. 12 nationalities have been enrolled on that. So this is a way in which we are trying to increase the number of people who are working towards pediatric endocrinology. So we have gone through a lot of topics today, and especially the topic of type 2 diabetes, in which Dr. Chetan talked about how difficult it is to manage children with type 2 diabetes once they develop it. And we all know about that. And the best way, of course, is to try to prevent it. And that's why prevention of childhood diabetes requires prevention of obesity, which again is easier said than done. And now, once obesity is becoming a truth, we will also need to explore options just beyond prevention and whether treatment could be options on that. And I would be talking specifically about one modern way of treatment which has been used both for type 2 diabetes as well as obesity, and how GLP based therapies can have a role in terms of management of pediatric obesity, particularly. There's a lot of word upon that. Before that, this 16-year-old boy with obesity presented with massive obesity, 46.7 BMI, had everything type 2 diabetes, fatty liver, and was advised bariatric surgery. Now, parents are not really ready for bariatric surgery. Do we have any options there or not? So I'll be focusing about the options of why, what, and how do the GLP analogs will have a role in that perspective. So first of all, why? We know that there has been a dramatic increase in obesity, and this is the data from the globe which shows 20 to 30-fold increase in burden of childhood obesity. Most important part, if you want to really control the complications, is to really curtail the BMI standard deviation score. So our studies has shown that if you want to cure pre-diabetes, you would be needing approximately 10% of BMI SDS loss. So if you want to know what is the appropriate loss in obesity, it is 10%. Similarly, fatty acid, what we found that most patients have persistent fatty liver over a period of time. And if you want to do something, you need to lose 5 to 10% of BMI standard deviation score. So this is the target of BMI. So whenever I am going to talk about various drugs, you should know that if they are doing a 5 to 10% loss, that is good enough. Otherwise, probably it's not that good from that perspective. We also know that there is a continuum in terms of complications. So it all starts with obesity, which results in development of metabolic factors, renal involvement, cardiac involvement, and all the things are amplified. And we need to break this cycle to achieve that. Otherwise, metabolic dysfunction will result into kidney disease, into heart disease, and all the complications happen. So we need to break the cycle early. So, what are the options which are there in terms of pediatric obesity? The options include lifestyle, medications, and the bariatric surgery. Now, if I talk about lifestyle, generally speaking, lifestyle has been found to be not very effective. In most cases, if you have a weight loss, there is a body mechanism by which itself it will counter regulate it. So, what happens is that if you are losing weight, the body has got a set point for leptin. As soon as the leptin level falls, they feel that this person is going to starve to death, and then they start to decrease the energy expenditure. So, in this regard, the response to fall of body fat is a decrease in leptin and an increase in ghrelin. And these parameters will then stabilize the weight, and further, there will be a weight gain. So there is always going to be a ceiling effect as far as the amount of weight that you will lose or the BMI you will lose while just nutritional or lifestyle intervention. That's typically 3 to 5%. So I said you need 10% to correct pre-diabetes. You need 5 to 10% for fatty liver. So this 3 to 5% is not going to make a huge difference in that perspective, and it is ill sustained and it will invariably be regained. What about the currently available drugs? Now, orlistat, the drug has been available for quite some time, but the amount of weight loss with orlistat is not going to be huge. You will have a benefit again of around 3%. So this is again not going to do any benefit. It is something which most people have left it. Metformin as a drug, everybody know that metformin is a drug predominantly for diabetes, PCOS or fatty liver. As a weight loss drug, it is not going to be effective. It is not going, there is a randomized trial which was done, but it was not found to be effective at all. It was very minimal, around 2%. So this is something which we should not be using unless there are other things like type 2 diabetes, NAFLD or PCOS. So our armamentarium of drugs is very limited. Drugs which are centrally acting have been found to have a lot of CNS problems, and that's why they're also not being approved in most scenarios. What about bariatric surgery? Now, bariatric surgery is clearly proven to be a highly effective therapy in terms of response, and it shows a decline of around 20 to 25% as far as BMI. This is the study from adolescents. So it's the most effective therapy for reducing BMI in adolescents, but there are a lot of other complications, including mortality. So most people, as was in this case, would not like to go ahead with bariatric surgery. So currently, lifestyle measures are only going to give us 3 to 5%, not sustained. Drugs are variable response, adverse effects, and bariatric surgery is high responsive, but there is a lot of morbidity. So what options do we have? We want a drug which is safe, selective, doesn't act on the central system, and is also effective at least 10% fall of BMI. This is the ballpark figure that we are going to chase out in that perspective. So what is the option? I'm going to focus predominantly about GLP. Chetan talked a bit about GLP. So this is basically a compound which is secreted via our intestine in response to intake of the carbohydrate. There are two predominant, the glucagon-like peptide and the gastric inhibitory peptide. Now, these have different actions. The GLP-1 will go and decrease the gastric emptying, so you will feel full most of the times. It will go to the brain and tell that, okay, we already have food now, don't eat any further. So food intake will come down, satiety will be induced. It is going to act on the pancreas to increase the insulin secretion, and insulin also is known to induce satiety. That is one factor, and is also going to inhibit glucagon release. So GLP-1 has got multitude of actions, and these actions in nutshell will cause increased satiety, reduce gastric motility, resulting in lesser food intake and possibility of weight loss. This is the basis of the incretin effect. There are multiple GLP-1 receptor analogs. We talked about liraglutide, exenatide, semaglutide is the one which has been developed a lot. A lot of talk has been there. Now we have dual agents along with the GIP, which include the tirzepatide, and then there is a triple therapy in which we have a combination of GLP-1, GIP, and glucagon also, which is coming up. So this is area wherein a lot of work has been done, particularly because the effects in the CNS is not like a neurotransmitter modulated. It is a direct metabolic mediated pathway from that perspective. So liraglutide and GLP-1 receptor analogs have multiple roles. They have a role in terms of overall reduction in visceral fat. So they are particularly helpful for individuals who have fatty liver and beneficials in that regards. They have been shown to reduce the fat mass as well as preserving muscle mass. So we have increase as far as lean mass is concerned, while there is a decline in terms of the fat mass in that regards. Now coming on to adolescent study, liraglutide was the first trial. Look at the figure. The amount of weight, the loss which is happening is to the tune of 5 to 6%. So the first drug for which approval was given by FDA is causing 5 to 6% loss in BMI. So from my side, it is not very good, but it was given an approval. So liraglutide is available as a daily injection and it had only moderate effects. So probably it was not a game changer from that perspective. However, there were some studies which were done using liraglutide and other GLP-1 receptor agonists in complicated scenarios like Prader-Willi syndrome. This study also did not find much benefit. So in a way, liraglutide is not a good drug as far as obesity management is concerned in children. Then came the second big agent, which was semaglutide. And if you look at semaglutide, what you're seeing a percentage loss of 15%. So this is a very good number. We are talking about 5 to 10%. Here there is a loss of 15%, which is clearly there. But what are you seeing after 68 weeks? After 68 weeks, when the drug is stopped, there is again a regain. Now, this is common for all GLP studies. As soon as you stop the drug, the weight tends to gain again. Proportion of children who are achieving weight loss, of course, is much more. So this is much more potent as compared to liraglutide. But of course, we have to look at various other factors in that perspective. So efficacy outcome clearly show that it is quite superior as an obesity agent. Change in BMI was 16.7% to be precise. There was more than 5% reduction in around 95% of cases. BMI SDS came down by 1 standard. So it was a good amount in terms of their weight loss of around 15 kg. So this was a good drug from that perspective. What about adverse effects? Anybody who has prescribed GLP-1 receptor analog knows that a lot of patients will come to us with bloating, abdominal pain, not feeling well, nausea. We have to tell them these things are common. 4 to 5% in this study and in general practice also will stop the drug. So best is to start at a low dose and then gradually build it up. Tell them that this is going to happen and this is going to improve. But if you are giving a weekly injection, then that may be a problem because you've given the injection, the effect may be there for quite some time. So this is a negative effect which is there. We should avoid drugs like prokinetic agents because they are going to nullify the effect. If you give a prokinetic, of course, the gastric motility will go up from that perspective. So the adverse effects are there. Now, what really has been found that in 45% children who are very obese, it was able to bring them off the obesity category. So this is one drug which can be game changer in the sense of reducing the overall amount as far as obesity is concerned. So semaglutide at the moment 2.4 milligram is not available. It's going to be available very soon. So I think this will be a good drug to be used in obese adolescents and we are all looking forward to this drug in that regards. And clearly the benefits are irrespective of the age, irrespective of the gender, irrespective of the obesity category. So it's quite a good drug across all obesity categories in adolescents from that perspective. Very importantly, conditions where we find it very challenging to manage obesity like hypothalamic obesity, also there has been benefits via semaglutide which has been found in that perspective. So semaglutide is one agent which has really brought the bar up for all the GLP-1 receptor analogs, and then came the role of dual agents. So these agents are going to focus two aspects. Tirzepatide is a drug which has been studied in adults predominantly. And what we are seeing here is a loss of around 21 to 22%. 5% for liraglutide, 15 to 16% for semaglutide in adolescents. This is for adults, not adolescents, but it is 21%. So this is a drug potentially which is going to do again a good work in terms of reduction. And again, what we are seeing as the dose increases, there is a good response in terms of body loss and weight loss and other parameters as well. There has been a recent study in NEJM, and this is a wonderful study which shows that if you give tirzepatide to obese individuals, you can prevent the development of diabetes And you can see over this 4-year period, the prevalence, there was no diabetes happening in this group, while those who were not being treated had a lot of diabetes. So this is another drug which is going to helpful. Of course, it is targeting two different strategies from that perspective. There has been no pediatric study there, but now there are AI models. Based upon that, they have predicted what will be the appropriate dose of tirzepatide. Tirzepatide is available in India now, and it's being used in adults predominantly. So they have tried to look at the dose, and they have come up that for adolescents, approximately 3.75 to 5 milligram will be a good enough dose in that perspective. And they have even calculated based upon the dynamics, but we need to wait for the studies at the moment. So tirzepatide is a good drug. And the evidence of this comes from the study of Alstrom syndrome. These patients are very refractory to therapy. And you can see when they were given dulaglutide, semaglutide, liraglutide, they did not have any response. As soon as tirzepatide came, somehow they had a good response. So this is just two patients, but probably we are talking about a novel mechanism which is going to add out in terms of response. Now, there are also novel agents which are focusing on three aspects, not only GLP1, but GIP, but glucagon also. This is an experimental study. This is more in terms of a mice model at the moment. But what you can see, the calorie intake has nearly come down to around 5 to 10% of what it is in these studies. So clearly, this is an agent. By targeting three aspects, you may get more benefits from that, but this we are waiting for that. Very recently, there was a phase 2 study on a once monthly GLP1 receptor analog. So probably now people have realized that GLP1 receptor analogs are the way to go forward in terms of managing obesity. So we have now daily to weekly and now monthly. And overall, this also has shown a good reduction of approximately 16 to 17% reduction. So we are now going to hear about this drug a lot in that perspective. So what we wanted was a safe drug which was selective and which was effective. So probably GLP-1 is a good drug in that direction. Semaglutide clearly has got good evidence in adolescents. Tirzepatide has got good evidence in adults. We need to wait for the picture. But at the moment, I think the availability of semaglutide will help many of these morbidly obese patients in which bariatric surgery is being planned.